Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 174 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the next question reads, PKP, a 4-year-old Hispanic girl who attends a day care facility 3 days each week, presents for her well child visit. Her vitals include a body temperature of 38.5 degrees Celsius. She has a chief complaint of rhinorrhea, and a left-sided bulging tympanic membrane. On reviewing her medical record, you establish that she has not received any vaccines since she was 2 months old. So my question to you is, which of the following would be the most appropriate pharmacologic intervention for PKP now? Would it be A. Initiate treatment for acute otitis media with ceftriaxone 50 mg per kilogram given IM times 1 dose and administer the first dose of a 2-dose series of Haemophilus influenza type B vaccine and 1 dose of 23-valent pneumococcal polysaccharide vaccine, or B. Initiate treatment for acute otitis media with co-amoxiclav dosed at 90 mg per kilogram per day orally in 2 divided doses for 5 days and administer 1 dose each of Haemophilus influenza type B vaccine and 13-valent pneumococcal conjugate vaccine, or C. Use watchful waiting for any progression of symptoms for the next 48 to 72 hours and administer the first dose of a 2-dose series of Haemophilus influenza type B vaccine and 1 dose of 23-valent pneumococcal polysaccharide vaccine, or would it be D. Use watchful waiting for any progression of symptoms for the next 48 to 72 hours and administer 1 dose each of Haemophilus influenza type B vaccine and 13-valent pneumococcal conjugate vaccine? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Use watchful waiting for any progression of symptoms for the next 48 to 72 hours and administer 1 dose each of Haemophilus influenza type B vaccine and 13-valent pneumococcal conjugate vaccine. According to 2013 guidelines for the management of acute otitis media in pediatric patients, watchful waiting prior to initiation of antimicrobial therapy is indicated for patients more than 2 years of age who present with non-severe symptoms. This patient's symptoms are not severe symptoms based on her unilateral bulging tympanic membrane and lack of fever of 39 degrees Celsius, otorrhea, and pain. This patient has missed key immunizations that could decrease morbidity associated with upper respiratory infections. She has not completed the vaccine series for Haemophilus influenza type B or pneumococcal vaccine. Based on her age greater than 2 years, she is a candidate for a single dose of Haemophilus influenza type B vaccine instead of the standard 3 or 4 dose series. Furthermore, she requires catch-up immunization with the 13-valent pneumococcal conjugate, PCV13, vaccine. Receipt of ppSV23 is not appropriate given her lack of comorbidities that would classify her as at high risk for invasive pneumococcal disease. Therefore, the use of watchful waiting for any progression of symptoms for the next 48 to 72 hours and administration of 1 dose each of Haemophilus influenza type B vaccine and PCV13 are appropriate for PKP. This patient needs to receive only 1 dose of Haemophilus influenza vaccine at this time based on her age, which exceeds 2 years. The correct pneumococcal vaccine for administration to this patient who has no comorbidities or high-risk conditions is the 13-valent conjugate vaccine as a single dose. Therapy with moxicillin, clavulanate could be considered in this scenario because 2013 guidelines for the management of acute otitis media, abbreviated as AOM, provide an option for initiating antibiotic therapy in patients more than 2 years of age with unilateral AOM. However, this would not be the best choice because of this patient's lack of severe symptoms and the presence of rhinorrhea, which is more often associated with a viral etiology than a bacterial etiology in patients with AOM. A short course of antibiotic therapy for 5 to 7 days is appropriate for patients 6 years of age or older with AOM. However, 7 days of therapy are recommended for patients 2 to 5 years of age. Giving 1 dose each of Haemophilus influenza type B vaccine and 13-valent pneumococcal conjugate vaccine is appropriate as catch-up for these vaccines in this patient. Ceftriaxone is not the preferred initial therapy for the management of acute otitis media (AOM). However, it is recommended as an alternative first-line therapy for patients who have failed to respond to initial antibiotic therapy within 48 to 72 hours. Amoxicillin 90 mg per kilogram per day by mouth remains the mainstay of primary therapy for AOM in pediatric patients. Therefore, although ceftriaxone could be a plausible recommendation, it does not represent the best option for managing this patient's AOM considering her patient-specific factors, such as age, past medical history, and lack of severe illness. Based on an age greater than 2 years, this patient needs to receive only 1 dose of Haemophilus influenza vaccine at this time. The correct pneumococcal vaccine for administration to this patient who has no comorbidities or high-risk conditions is the 13-valent conjugate vaccine as a single dose. Please advance to the next question. And the next question reads, SPL, a 9-year-old male patient presents to your pediatric accident and emergency department with a chief complaint of severe ear pain not relieved by ibuprofen dosed at 10 mg per kilogram per dose given via gastrostomy tube every 8 hours as well as fever of 40 degrees Celsius. He has a past medical history significant for cerebral palsy, tympanostomy tubes for recurrent acute otitis media, acute bacterial rhinosinusitis for which he has been receiving therapy with co-amoxiclav at home and today is day 5 of treatment. His signs and symptoms include shortness of breath, increased output from his gastrostomy tube that seems to coordinate with his co-amoxiclav doses but is much worse today. So my question to you is, which of the following represents the best antibiotic therapy to administer via gastrostomy tube to SPL after discontinuing co-amoxiclav based on his presentation? Is it A. levofloxacin 20 mg per kilogram per day in 2 divided doses for 5 additional days, or B. clindamycin 30 mg per kilogram per day in 3 divided doses plus cefixime 8 mg per kilogram per day in 2 divided doses for additional 7 days, or C. doxycycline 4 mg per kilogram per day in 2 divided doses for 10 additional days, or is it D. cefdinir 14 mg per kilogram per day in 2 divided doses and azithromycin 10 mg per kilogram per day for 5 additional days? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Levofloxacin 20 mg per kilogram per day in 2 divided doses for 5 additional days. This patient is displaying signs of a type 1 hypersensitivity reaction probably caused by the amoxicillin component of his current treatment regimen. In pediatric patients with a type 1 hypersensitivity reaction, therapy for acute bacterial rhinosinusitis involves the use of a fluoroquinolone instead of therapy with clindamycin plus a third-generation cephalosporin because of concerns about cross-reactivity between cephalosporins and aminopenicillins. The use of macrolide antibiotics is discouraged because of community-wide resistance displayed by Streptococcus pneumoniae isolates, making this choice inferior to the other treatment options provided despite the inclusion of a third-generation cephalosporin. Although this patient is 8 years of age, doxycycline is a viable treatment option. However, doxycycline does not represent the best choice for this patient based on recommendations in the 2012 Infectious Diseases Society of America Clinical Practice Guidelines for Acute Bacterial Rhinosinusitis Management in Children and Adults, which advise against the use of tetracyclines in children. Although consideration of a shorter course of antibiotics of 5 to 7 days for the treatment of rhinosinusitis is encouraged in the 2012 Infectious Diseases Society of America Clinical Practice Guidelines for Acute Bacterial Rhinosinusitis in Children and Adults, the recommended treatment duration remains 10 to 14 days for children. Levofloxacin will provide adequate coverage for the most common bacterial causes of acute otitis media in this complex patient who is not antibiotic naive: Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis. Therefore, 5 additional days of levofloxacin is appropriate for this patient who has received 5 days of amoxicillin clavulanate. This patient is displaying signs of a type 1 hypersensitivity reaction probably caused by the amoxicillin component of his current treatment regimen. In pediatric patients with a type 1 hypersensitivity reaction, therapy for acute bacterial rhinosinusitis involves the use of a fluoroquinolone instead of therapy with clindamycin plus a third-generation cephalosporin because of concerns about cross-reactivity between cephalosporins and aminopenicillins. Therefore, clindamycin plus cefixime is not a good choice for this patient. Please proceed to the next question. And the next question reads, the antimicrobial stewardship team at a university hospital in Egypt, a facility with 450 adult beds and 50 pediatric beds, has decided to create clinical pathways for the most common respiratory infectious diseases encountered at the facility and would like to include all service areas. 60% of pediatric patients presenting to the facility are unvaccinated or receiving vaccines on a delayed basis. According to the local antibiogram, 30% Streptococcus pneumoniae strains are resistant to ampicillin and 5% are resistant to ceftriaxone. 50% of Haemophilus influenza isolates in this university hospital are beta-lactamase positive. 24 months ago 60% of the total respiratory pathogens isolated from pediatric upper respiratory cultures were Moraxella catarrhalis. So my question to you is, which of the antimicrobial therapies listed below would you recommend as the preferred empiric therapy for the acute otitis media (AOM) clinical pathway for pediatric patients at this university hospital? Would it be A. clindamycin 30 mg per kilogram per day orally in 3 divided doses plus cefpodoxime 10 mg per kilogram per day orally in 2 divided doses, or B. Cefixime 8 mg per kilogram per day orally in 2 divided doses, or C. Cefdinir 14 mg per kilogram per day orally in 2 divided doses, or would it be D. Amoxicillin clavulanate 45 mg per kilogram per day orally in 2 divided doses? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Cefixime 8 mg per kilogram per day orally in 2 divided doses. A third-generation cephalosporin would be most appropriate for the AOM clinical pathway at this hospital because of the Streptococcus pneumoniae ampicillin resistance rate above 10%, the high percentage of pediatric patients who are unvaccinated or inadequately vaccinated, and the high prevalence of Moraxella catarrhalis isolates that are known to produce beta-lactamase enzymes that would not be adequately covered by first-line therapy with amoxicillin or amoxicillin clavulanate. The local antibiogram and patient populations served by this hospital must be taken into consideration when selecting the best empiric therapy for inclusion in the clinical pathway because antimicrobial stewardship is not just about using therapy with the narrowest antimicrobial spectrum of activity but also the timely initiation of the most appropriate therapy to manage the most likely organisms in patients with respiratory infections. The amoxicillin clavulanate dosage based on the amoxicillin component would need to be at least 90 mg per kilogram per day to achieve adequate exposure to overcome the alteration in penicillin-binding proteins anticipated as a primary mechanism of resistance exhibited by Streptococcus pneumoniae. Therefore, amoxicillin clavulanate 45 mg per kilogram per day in 2 divided doses is not a good choice for empiric therapy in the AOM clinical pathway at this hospital. Although Kevahame provides broader coverage than is typically desired, the local antibiogram and patient populations served by this hospital must be taken into consideration when selecting the best empiric therapy for inclusion in the clinical pathway because antimicrobial stewardship is not just about using therapy with the narrowest antimicrobial spectrum of activity but also the timely initiation of the most appropriate therapy to manage the most likely organisms in patients with respiratory infections. Cefixime is the best choice for empiric therapy in the AOM clinical pathway at this hospital. Although clindamycin plus a third-generation cephalosporin is a potential option for pediatric patients who are allergic to penicillins, this combination is not recommended as a first-line empiric therapy for all patients. The use of clindamycin to provide coverage for methicillin-resistant Staphylococcus aureus (MRSA) is not needed because the top 3 bacterial pathogens in AOM are Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis. Therefore, clindamycin plus cefpodoxime is not a good choice for empiric therapy in the AOM clinical pathway at this hospital. Please progress to the next question. And the next question reads, ATP, a 65-year-old female patient presents to the primary care clinic with complaints of nasal discharge, cough, and frontal headaches that have been intermittent over the last 2 weeks. Her past medical history is significant for congestive heart failure and type 2 diabetes mellitus. ATP reports having a cold during that time and thought she was getting better until 72 hours ago when her symptoms worsened. A diagnosis of acute bacterial rhinosinusitis is made. The healthcare provider would like to initiate antibiotic therapy. So my question to you is, which of the antimicrobial regimens listed below would be the best initial empiric therapy for ATP? Would it be A. Cefdinir 300 mg orally twice daily for 5 days, or B. Moxifloxacin 400 mg orally once daily for 7 days, or C. Co-amoxiclav 500 mg orally thrice daily for 10 days, or would it be D. Co-amoxiclav 2 grams orally twice daily for 5 days? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Co-amoxiclav 2 grams orally twice daily for 5 days. The empiric drug of choice for acute bacterial rhinosinusitis, abbreviated as ABRS, is amoxicillin clavulanate, according to the 2012 Infectious Diseases Society of America Clinical Practice Guidelines for Management of ABRS in Children and Adults. The use of high-dose amoxicillin clavulanate, i.e., 2 grams orally twice daily, instead of 500 mg orally 3 times daily is appropriate for this patient because of her advanced age, greater than 65 years, and comorbid disease states, diabetes mellitus and CHF, and concerns about penicillin non-susceptible Streptococcus pneumoniae. The recommended duration of treatment for adults with ABRS is 5 to 7 days. Therefore, amoxicillin clavulanate 500 mg by mouth 3 times daily for 10 days is not the best choice for this patient. Fluoroquinolones are not recommended as first-line therapy in the 2012 IDSA Clinical Practice Guidelines. Moreover, moxifloxacin provides anaerobic coverage, which may not be needed for this patient. Cephalosporin antibiotics are no longer recommended as first-line therapy for management of ABRS. Therefore, cefdenia is not a good choice for this patient. Please proceed to the next question. And the next question reads, TNA, a 35-year-old male patient presents to your hospital with a chief complaint of fever with a body temperature of 39.5 degrees Celsius, purulent nasal discharge, facial pain surrounding the ethmoid region. He has no known drug or food allergies. He was initiated on co-amoxiclav 500 mg orally thrice daily for acute bacterial rhinosinusitis, ABRS. TNA reports that the pain and discharge have worsened during the time since he began taking it 2 days ago. TNA reports compliance with his antibiotic regimen. So my question to you is, which of the following is the best alternative to amoxicillin clavulanate for treating his ABRS? Is it A. levofloxacin 500 mg orally once daily, or B. doxycycline 100 mg orally twice daily, or clindamycin 300 mg orally thrice daily plus cefixime 400 mg orally twice daily, or is it D. co-primoxazole 1DS tablet orally twice daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. doxycycline 100 mg orally twice daily. Trimethoprim sulfamethoxazole is not an appropriate alternative to amoxicillin clavulanate for this patient because of high rates of resistance among Streptococcus pneumoniae and Haemophilus influenza, which are common pathogens in patients with ABRS. Clindamycin plus cefixime is an alternative to amoxicillin clavulanate for children with ABRS and evidence of non-type 1 hypersensitivity, but it is not indicated for adults with ABRS. When a patient has worsening ABRS symptoms within 72 hours after initiation of appropriate first-line therapy, the agent should be changed to broaden coverage for pathogens that may exhibit resistance to beta-lactam antibiotics even in the presence of a beta-lactamase inhibitor, i.e., this patient's amoxicillin clavulanate. Doxycycline is the best alternative for this patient because it provides adequate coverage for the most common upper respiratory pathogens associated with ABRS, which are Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis. Although levofloxacin is an alternative to amoxicillin clavulanate for the treatment of ABRS, the FDA warns against the use of fluoroquinolones when other alternatives are available because of the risk of adverse effects from fluoroquinolones. Doxycycline is the best alternative for this patient because it provides adequate coverage for the most common upper respiratory pathogens associated with ABRS, which are Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 175.